primary aldosteronism. So Greg, please take it away.
Thanks, Greg. So the topic I'm going to talk about today is how common is primary aldosteronism. And the way I kind of thought of this kind of slant to the topic is I was recently asked to write a review article trying to answer this question. And I quickly realized it's a very tricky question to answer as the definitions of what this disease is has changed over time, and our understanding of the physiology of this disease has also changed. And I think looking at it from a historical perspective gives us some insight into what this disease might look like in the future. So I thought it would make for a good grand rounds. So nothing to disclose. In terms of objectives for the talk, I'm going to start by kind of reviewing the physiology of primary aldosteronism and including normal aldosterone secretion as well. Then I'll talk about the limitations of some of the conventional definitions of primary aldosteronism that have evolved over time, and talk a bit about how they may be quite outdated at this point. And then we'll finish up by talking about how in the future we may take a mechanism-based approach to identifying primary aldosteronism, and as well as how to treat it. So I think the first step here is always to kind of review the physiology of this disease. And it's a common point of confusion about what is primary aldosteronism, because you can have hyperaldosteronism that's normal, which is secondary aldosteronism. So I just kind of wanted to look at how you compare these two. And I will tell you ahead of time that looking at renin is really the way you can kind of distinguish one from the other. So I think it's important first to talk about normal hyperaldosteronism. And this is what we call secondary aldosteronism, which again, renin is the kind of the thing that the chemical that helps you distinguish one from the other. So this is renin dependent. And this is kind of a simplified diagram of the nephron here. And so a typical scenario where you would see secondary aldosteronism is intravascular volume depletion. And so what happens here is this: if you have intravascular volume depletion, this is sensed in the kidneys, and there you're going to secrete renin and angiotensin II. Now, with high levels of angiotensin II, this acts proximally on the kidney, causing potent sodium reabsorption, which is what you want because you started with a setting of intravascular volume depletion. So you want to reabsorb sodium as much as possible. And this is generally done proximally in the kidney. Now, as you know, the RAS pathway involves renin, angiotensin II, and eventually aldosterone. So you're going to get high levels of aldosterone here, so hyperaldosteronism, which is renin dependent. And so aldosterone binds to the mineralocorticoid receptor of the principal cell, and you get reabsorption of sodium through the ENaC channel. Now, what's different about this is because you have so much proximal sodium reabsorption, there's actually very little decrease. There's very little distal sodium delivery because all of the sodium is being reabsorbed proximally. So there's not that much sodium flow to the distal nephron. So you're actually not getting that much reabsorption of sodium through the ENaC channel just because there's not that much sodium distally here. And because of that, you're not getting that much excretion of potassium or acid. So you don't typically get hypokalemia or metabolic alkalosis as you would see with primary aldosteronism. So this is renin-dependent aldosteronism, commonly due to volume depletion. Now, you can probably think of other scenarios where this same physiology would be in play. So other signs where you're intravascular volume depleted, but maybe total body overloaded, so like heart failure or liver disease. Or if you think about the nephron just seeing a lower blood supply, like renal artery stenosis has a similar physiology. So what happens here is you get optimal sodium reabsorption and volume expansion, which in the setting of volume depletion is what you want because you're combating the initial insult, and you get decreased distal sodium delivery. And because of that, you have minimal potassium excretion. And I always like to show this example of the Yanomami tribe. Now, this is a group that's been studied. So this is a tribe that lives in the rainforest of Brazil and Venezuela. And they've been studied a lot over the years in terms of their RAS activity, because what's unique about their diet is they have a very low sodium intake in their diet. And people have always wondered, how do they survive with this? How does their RAS system adapt to this? And they're kind of a main reason of how we understand why low sodium intake is actually beneficial in terms of blood pressure. So some of the studies they've done on the Yanomami, so this study dates back to the 1970s, where they compared basically RAS activity between North Americans and the Yanomami tribe. So first they looked at 24-hour urine sodium excretion. So this is reflective of dietary sodium intake. So you can see that they excrete about 1 millimole of sodium in a 24-hour period compared to us, where it's almost 200. Now, how would they adapt to that if the RAS pathway? Thinking back to that diagram I just showed you, well, they should, with such low sodium intake, they should be revving up the RAS activity. And indeed they do. So if you look at their plasma renin activity level, it's much, much higher than ours is. And if you look at their urine aldo excretion, you would expect with higher RAS activity that they'd have high levels of 24-hour urine aldo excretion. And indeed they do. And you can see just how different it is. Just to give you some kind of perspective on this, when we diagnose primary aldosteronism in the setting of high sodium intake, the cutoff for calling somebody having primary aldosteronism, that would be 12 on this, so 12 micrograms of aldo excretion over 24 hours. And you can see that they're at about 75. Now, again, this is different because it's in the setting of a low sodium state, but they're able to clearly rev up their RAS activity pretty impressively. Now, with that, do they have higher blood pressure because of this high aldo level? Well, no, their blood pressure is actually lower than ours. So this population actually has one of the lowest blood pressures of any people around the world. Okay. Okay, sorry, let me switch the slides here. There's some issues here with the, can you guys see the slides better now?
It's still not on the presenter view, Greg. Like I don't know what it.
Okay, let me try again here. Is that any better? Or the same?
It's still the same.
Okay. Sorry about that. Is that better?
I can't see the slides on my screen right now.
I don't see any other way to share it here, unless somebody else is able to stop by and.
I would just go back to what you were doing there, Greg, I guess.
Okay.
Are you able to just to click the little icon there, that little, yeah.
That's what I've been doing.
Oh, that's weird.
Are you seeing any of the slides right now?
Yeah, but it's just I think they're, no, anyway, I would just keep going for now.
Okay. In addition to, thinking of back to the Yanomami tribe, so the other kind of, I think, intriguing part of this is there's actually this pit viper that lives in the area of Brazil where the Yanomami tribe lives. And so you can see them, this is kind of a picture of them getting the poison out of the snake. And so what's interesting about this is the evolutionary pressures that led to these pit vipers developing their poison, which if you think about it, if they live with the Yanomami tribe and that's kind of their natural enemy, is what poison would be perfect for to have in their venom here. And it would obviously be something, the Yanomami tribe is so reliant on their RAS activity being hyperactive, it would be something like an ACE inhibitor, which blocks your ability to rev up your RAS system. And so this is actually how the first ACE inhibitors, captopril, was developed, was through the venom of this snake. So contrast that with this secondary aldosteronism to primary aldosteronism. So again, renin is the big distinguishing feature here. So this is renin independent. So in this setting, you have some autonomous source of aldosterone secretion. So this triangle is supposed to reflect the adrenal gland. So you have autonomously secreted high levels of aldosterone. Now, with that, you're going to have this chronic sort of volume expansion. And with that, your kidneys are going to sense that, and you're going to shut off your RAS activity. So you have low levels of renin and angiotensin 2. And because of the low levels of angiotensin 2, you don't get this proximal sodium reabsorption you do with secondary aldosteronism. And with that, you get high levels of distal sodium delivery to the distal nephron here. Now, you still have high levels of ALDO, and so that's going to bind to the mineralocorticoid receptor. But now, because you have high levels of distal sodium delivery, you have high levels of sodium reabsorption to the ENaC channel. And this creates a vicious cycle. So you get high levels of distal sodium delivery, high levels of sodium reabsorption, which causes volume expansion, high blood pressure. And with that, with the high levels of sodium reabsorption to the ENaC channel, you get a lot of efflux of both potassium and acid. So you get hypokalemia and metabolic alkalosis, which is kind of the classic triad we typically think of in this disease. So thinking of how primary aldosteronism affects us in terms of outcomes. So the main focus of prior research has looked at cardiovascular outcomes, and I'll share a fairly recent meta-analysis where they looked at a variety of cardiovascular outcomes. And in most of these studies, they compared patients with primary aldosteronism to those with essential hypertension and looked at cardiovascular outcomes. So first they looked at coronary disease. And you can see here they break it down by studies that are not matched and studies that are matched. And when they're talking about matching, they match based on blood pressure. So two patients with the same level of blood pressure, you can see that patients with primary aldosteronism, even if you match based on blood pressure, they have substantially higher rates of cardiovascular disease. So it's about 70% higher odds of coronary disease. When you look at it for stroke, it's about threefold higher odds for stroke, even independent of blood pressure compared to essential hypertension. For heart failure, it's about twofold higher odds. And for AFib, it's almost fourfold higher odds. So that's why it's important to diagnose this disease early and start people on appropriate treatment. And given this audience, I also mentioned the kidney effects, which are not as talked about, but there's very clear evidence in the literature that primary aldosteronism also leads to adverse kidney disease. So as you can imagine, with volume expansion with high levels of autonomous aldosterone secretion, you get early glomerular hyperfiltration. And associated with that is high rates of albuminuria. And so their EGFR may actually be higher early on, especially before they start targeted treatment. But what you'll typically see is that they have a steeper long-term EGFR decline and higher rates of CKD. And I think this is kind of highlights why we may have seen the results we did with the Fidelio DKD study, which was recently published in the New England Journal, where they took patients with CKD due to diabetes, and they randomized them to placebo or finerenone, which is a newer MR antagonist, which is a bit of a cleaner MR antagonist than spironolactone. And they looked at the primary outcome was 40% EGFR decline, kidney failure, or death over the study period. And what they saw was that there was lower rates of the primary outcome with finerenone, which in my mind, this may be due to, as I talk about later, there's a large percent of the population that has autonomous aldosterone secretion, and it may be that population that are really benefiting from the MR antagonist. So in terms of our traditional treatment approach to primary aldosteronism, there's two flavors of it. So about 1/3 of the cases are unilateral and typically due to an adenoma. And the recommended treatment for these people, if they're healthy enough to go to surgery, is adrenalectomy. The remaining 2/3 is bilateral disease. And this is typically due to hyperplasia. And the treatment for these individuals is generally sodium restriction and lifelong MR antagonist therapy. Now, I wanted to kind of take you through this timeline of primary aldosteronism and how common it is and kind of how this has evolved over time. So when we looked back to the kind of birth of primary aldosteronism, it goes back to 1955. And this is Jerome Kahn, who obviously Kahn syndrome is named after. And he described the first case of primary aldosteronism at the University of Michigan. So he had an interest at the time. So this is the age when adrenal hormones were just being developed or being understood and understanding their mechanisms of action. And so Dr. Kahn was very interested in these pathways. And he had a patient present to him in 1955 that was a 34-year-old female who presented to him with weakness, periodic paralysis to the point that her legs were giving out and she basically could not stand. She had tetany, pretty significant hypokalemia with potassiums of 1.6 to 2.5, metabolic alkalosis, polyuria, very severe hypertension, 176 over 104 initially, and no evidence of glucocorticoid or androgen excess. So he initially realized that there was probably some abnormal adrenal physiology in this individual. And he asked her if he could admit her to the hospital for 14 days and put her through a battery of tests to try to sort out what exactly was going on. 14 days quickly turned into 200 and over 200 days, and she spent almost a year in the hospital while they tried to sort out what was going on with her. They eventually found out that she had very high levels of urinary aldosterone, and he figured it was coming from the adrenal glands. So he had actually convinced the surgeons that the right treatment approach would be to take her for exploratory surgery and remove both adrenal glands. So the initial plan was to do bilateral adrenalectomy, which, as you can imagine, may have caused all sorts of problems if that had actually occurred. But this is kind of a quote that from that time where he says, "To the immense delight of Kahn and those in the operating room, the surgeon, Dr. Baum, encountered a right 13-gram adrenal tumor, which was removed while leaving the contralateral gland intact." So rather than take out both adrenals, they ended up taking out just the one because it had a huge nodule on it. The patient's postoperative studies showed an almost total reversal of the preoperative metabolic and clinical abnormalities, and a new era had arrived in the study of hypertension and adrenal mineralocorticoids. And so in my mind, this is one of the earliest examples of personalized medicine, where they identified an individual's pathophysiology and targeted treatment at that specific cause. And this woman actually had completely normal blood pressure and completely normal potassium after the surgery. So since following up on that case, Dr. Kahn went on to demonstrate that the biochemical phenotype of primary aldosteronism is low renin, so renin suppression, along with inappropriate aldosterone secretion. Now, there's always a question of what exactly constitutes renin suppression. And this is kind of depends on who you ask. Most of these studies are done on plasma renin activity level, where the convention is to say less than 1 is suppressed. Now, we use direct renin concentration here, and so I'm always asked, what is a suppressed renin with direct renin? I generally think of less than 10. Some people will say less than 8, but that's generally what I think of. And as I mentioned here, renin suppression is really the sine qua non of this condition, so it's something you have to have to make the diagnosis. But Dr. Kahn went on to describe about 145 additional cases over the next decade after the initial one that he described. And he estimated that up to 20% of patients with essential type hypertension actually had primary aldo. So moving on from the 1950s to the 1970s, this was when the birth of the term low renin hypertension developed. And so what is low renin hypertension? Well, it's patients with hypertension who have low renin, but aldosterone levels that are not high enough to meet the definition of primary aldosteronism. And with that, there came a debate about the true prevalence of PA. So again, here's low renin hypertension. So soon after Dr. Kahn's work, and he mentioned that renin suppression was kind of the hallmark of primary aldosteronism, they found that low renin was very common in all forms of hypertension. And so this term low renin hypertension was developed for people with low renin, but not high enough aldo levels to call primary aldosteronism. And so you can see this very kind of, obviously the analyses are not as in-depth as we do these days, but where they compared normal subjects on the left and looked at their plasma renin activity level, and hypertensive patients on the right, where they looked at the distribution of renin levels. And you can see patients with hypertension, even outside of primary aldosteronism, tend to have much lower renin levels than normal subjects. Over time, they showed that patients with low renin hypertension had other features of mineralocorticoid excess, where they had higher blood pressure, lower potassium, higher potassium excretion. And similar to patients with primary aldosteronism, they found that patients with low renin hypertension are particularly sensitive to aldosterone inhibitors. So their blood pressure is reduced significantly with MR antagonists and ENaC inhibitors. And many now believe that primary aldosteronism and low renin hypertension lie on a continuous spectrum, and that the distinction we kind of laid to these two diagnoses is kind of arbitrary because they behave fairly similarly. And then there was debate about the true prevalence of primary aldosteronism. So Dr. Kahn said he thought it might be up to 20% of people with hypertension. This was disputed by a number of different centers. And so there are several reports of PA being very rare in like the 1 or 2% sort of range for hypertension patients. And that kind of influenced mainstream thought, and PA was relegated to kind of a zebra diagnosis in most medical textbooks, which I think still carries along to this day. Now, looking back, the low prevalence reported was likely due to varying definitions of PA, because there was no standard definition, and there really isn't today either. And the diagnostic requirements during this early time period was very, very strict, as I'm going to show you shortly here. So to make the diagnosis of PA originally, according to Dr. Kahn, this is what was required to diagnose in a patient before you could actually diagnose them with primary aldosteronism. And at this time, he only considered it unilateral PA, where they had an adenoma that you could surgically remove. So first, to diagnose this back in the early days, somebody had to have hypertension, hypokalemia, metabolic alkalosis, things we typically think about. They also had to have high urinary aldo, which we would typically think of. But then you get into things like having to have the Shavstock and Trousseau signs, cardiac enlargement, normal 17-hydroxycorticosteroids, alkaline urine, polyuria unresponsive to water deprivation or vasopressin, low sweat sodium. So you can imagine if you had to kind of check off all these boxes to make a diagnosis, we'd almost never diagnose somebody with primary aldosteronism, but this was the earliest diagnostic criteria. And the reason he made it so strict was he said that in a condition whose diagnosis must lead to surgery, one desires infallible preoperative diagnostic criteria. But he also says that if we insist on all these classic findings, we will be able to diagnose only about 30% of the cases, and I would argue it's probably less. Undoubtedly, this figure will drop much further as the ability to diagnose PA at an earlier or milder stage of its development increases. And he then went on to postulate that Conn syndrome would represent a wide spectrum of severity and go beyond just unilateral disease into conditions where it affected both adrenal glands, which we now know is actually the more common phenotype. So this leads us to the 1980s, and this was when the aldosterone to renin ratio was created. So this is the earliest study where they've mentioned the ARR. And you can see the ARR, which we all know is a screening test for primary aldosteronism now, was developed, and it was more so developed to look for aldosterone-producing adenomas rather than bilateral disease. And so this is a study where they took about 350 patients with hypertension, and they looked at the whole spread of ARRs in this population. So the white boxes represent people who did not have aldosterone-producing adenomas. The black boxes show patients who did. And you can see kind of there's a cutoff here where if you set the threshold at a certain level, patients beyond that ARR tend to have aldosterone-producing adenomas, and those with lower ARRs did not. But it's important to mention here, the ARR was created to pick up aldosteronomas, not primary aldosteronism. And as we'll talk about, that kind of meaning of the ARR has changed over time. So the ARR was rapidly adopted and to this day remains the diagnostic entry point for primary aldosteronism. So it's how we screen for this disease. But you have to remember that it's kind of how its use is almost imperceptibly changed from a test for aldosteronoma to a test for aldosteronism. And as the ARR is disproportionately determined by renin, so the denominator is a much bigger driver of how high your ARR is. A lot of people argued that ARR was more a test for low renin hypertension rather than primary aldosteronism, though, as I mentioned, this may just kind of be on the same spectrum of disease anyway. So the ARR began to be applied to a spectrum of disease beyond just aldosterone-producing adenomas. And one of the problems with this is PA has no external dichotomous gold standard. So the closest thing to a gold standard is if you put somebody on an MR antagonist, then their blood pressure drops substantially, or you take out their adrenal gland and their disease is cured. But obviously, for most patients, there's no ready available gold standard to prove this disease. And so there was an arbitrariness arose to where to set a threshold for ARR. And if you go center to center, you'll see everybody has a different ARR cutoff for what they consider abnormal. And it also became not clear what we were trying to find with the ARR. Were we looking for adenomas that you could surgically remove? Or were we looking to make the diagnosis of PA just to justify giving a patient an MR antagonist, which we wouldn't typically do? And so with no dichotomous gold standard anchor to set the ARR threshold and a variety of different hormone assays, because aldo and renin are measured different ways at different centers, every individual center ended up developing their own definition of what ARR threshold to set, and how they set it varied center to center. So some looked at surgical cases and looked at what the ARRs were at their center and set some ARR threshold. Some people looked at these confirmatory tests, which there are about 4 different confirmatory tests that we do to try to confirm a diagnosis of primary aldosteronism after a positive ARR screen, which generally involve aldosterone suppression tests, which the most common would be giving somebody an oral salt load and measuring their 24-hour urine aldo excretion, or doing saline infusion and seeing if their serum aldo level drops. So these confirmatory tests kind of give you a sense of, are they autonomously secreting aldo or not? And so that's one way that we use to try to confirm the diagnosis now. Other centers set the ARR threshold just looking at normal subject range and saying, if 95% of the people have this ARR, that's normal, and the 5% above that, we call abnormal. So there's all these different ways that different centers set the ARR threshold, which makes it very hard to compare one center versus another. Now, if you look at the guidelines of what ARR threshold to set, this is what you'll find. And so this is the most recent Endocrine Society guidelines. And you can see it's a very confusing table, because they look at PRA, so plasma renin activity, and direct renin concentration. So different centers will use different assays for renin, and the units change. And so, and in Aldo, there's several different units as well. And so you have to look at which units are unique for your center. So here in Ottawa, we use plasma aldosterone concentration as picomoles per liter, and direct renin concentration as nanograms per liter. And so this is what the guidelines say we should set our thresholds at. And so, but there's two numbers. So because these experts who kind of set these couldn't agree either. So they said it at some said 144, one said 192. I don't really pay that much attention to these anyway, because I think you have to look at the renin and aldo levels individually anyway. But this is kind of what the guidelines say. But again, they're very arbitrary and just largely expert opinion. And I think they're very likely to change in the next iteration of the guidelines. So given the wide variation in definition of ARR and populations that they were looking at, it became almost impossible to meaningfully talk about the prevalence of PA, because you had different ARR definitions. And these, so you can see this is from a meta-analysis where they looked at a number of different studies that looked at the prevalence of PA. Now, the problem is they've had different ARR thresholds. They looked at different patient populations. So some looked at hypertension, some looked at resistant hypertension, and they had different confirmatory tests too. And so you can see the prevalence ranges from 1% to over 30% here. And it's just because there was no uniform way to actually determine the prevalence. And so this meta-analysis that was published in 2016, they said prevalence estimates varied from 3 to 13% in primary care and from 1 to 30% in referral centers. And the heterogeneity was too high to establish any sort of point estimate for what the prevalence of PA is. And they go on to conclude that it's pointless to claim low or high prevalence of PA based on published reports because of this. So moving to kind of the past decade and the more modern day studies on primary aldosteronism, what's kind of newer in this field is a recognition of a continuum of renin independent aldosteronism. So if you look at the guidelines on who to screen for PA, this is who they'll tell you that you should be screening. So severe resistant hypertension, and so they define that as blood pressure greater than 150 over 100, over 140 over 90 despite 3 medications, or less than 140 over 90 but on 4 or more medications. And then hypertension plus some other syndromes, so hypertension and hypokalemia, which can be spontaneous or diuretic induced. I think that's often forgotten, is that if you're on hypokalemia and primary aldosteronism is often brought on by giving diuretics. So not everybody gets hypokalemic on diuretics, but somebody with PA is very kind of susceptible to that occurring. Hypertension plus an adrenal nodule, hypertension and sleep apnea, hypertension and early onset hypertension or stroke in the family, or hypertension and a first degree relative with PA, because some of these are genetic etiologies. So these are kind of who they say to screen, but we now recognize that PA commonly occurs in populations beyond these. And so that's why I think in the next iteration of guidelines, we're likely to see the guidelines on who to screen to change quite dramatically. So let's look at some populations outside of these kind of standard PA populations. So PA in mild to moderate hypertension. So there's been a couple of studies looking at that. The one I'm going to show you here is from Italy, where they looked in primary care hypertensive patients before they started on any medications. And so they screened all of them with the ARR, and 232 screened positive. And then they followed up with confirmatory testing and found that 99 had PA. Now, when you look at their whole hypertension population, that's about 6% that meet the diagnosis of primary aldosteronism. And if you break it down by hypertension into stage 1, stage 2, and stage 3, is very prevalent in stage 3 hypertension, but you can see even in stage 1 and 2, which are populations we wouldn't typically screen based on the guidelines, PA is still quite prevalent there. And this has been shown in other studies as well. So there was a study in Chile where they did a similar kind of technique where they screened 609 hypertensives, 63 screened positive. They did confirmatory testing, and again, about 6% of the population has PA by these conventional criteria. And again, more prevalent in more severe hypertension, but even prevalent in stage 1 and stage 2 hypertension. On the bottom is a study from the US where, again, screened stage 1 hypertensives for PA, 79 screened positive, and with confirmatory testing, 19% were confirmed to have PA. So these are large numbers of the hypertensive population that have PA and are populations where we would never typically screen. Now, how about pre-hypertension? So there was a small study in Japan where they did a kind of a similar approach. They took 44 pre-hypertensives, screened them all with an ARR, 10 screened positive, and out of those with confirmatory testing, 7% were confirmed to have PA. So it's prevalent even in pre-hypertension. And how about going all the way to normotension? So this was a study done in the US where 210 normotensives, and this was a selected population that had a suppressed renin, so a PRA less than 1. And here they started with confirmatory testing. So out of those 210, 29 were confirmed to have PA, and these are normotensive individuals. So 14% meet the diagnosis. And then they looked back to see how many would have actually screened positive with the ARR, and it was only 6%. So it tells you that the ARR is not a very sensitive test, and I'll talk more about that as a little bit later. This is another interesting study that was done in Greece where they took 100 normotensives, and again, they started with confirmatory testing. So 13% here were confirmed to have PA, so 13 out of the 100. What's interesting about this study is, so again, they're normotensive, so it doesn't really matter. They followed them for the next 5 years after making this diagnosis, and it turns out that 11 of the 13 that were confirmed to have PA at normotension developed hypertension over the next 5 years, so 85%, compared with 23% of the people that did not have PA. So that gives you an odds ratio of over 18. So obviously this does clinically matter if you meet this criteria for PA, but your blood pressure is still normal at the time. And this is a kind of a landmark study that was published in the Annals of Internal Medicine earlier this year, where they looked at the unrecognized prevalence of PA. And so this was a study across 4 US academic medical centers where they looked at, and these were all centers where they had done confirmatory testing for PA with an oral salt load and 24-hour urine autoexcretion. And based on their units, again, the cutoff is 12 micrograms. And so that's the dashed line you can see here, which is the threshold for diagnosing somebody with PA. And they looked at this across a large number of patients with untreated normotension, stage 1 hypertension, stage 2 hypertension, and resistant hypertension. And so this is confirmatory testing, guideline recommended of how many actually have PA. And so resistant hypertension, 24%, stage 2 hypertension, 21%, stage 1 hypertension, 16%, and untreated normotension at 9%. So you can only imagine how many of these cases we miss, because for how many patients we see with PA compared to these numbers and the whole population with hypertension, we're missing a ton of these cases. And I will mention that the threshold of 12 here with this dotted line is a bit debated as well, and that a lot of people think it's too high. There's a lot of evidence that even if you set this threshold at 6, so the line would go even lower and you'd have much higher percentages as well, that at the threshold of 6 that people display some degree of autonomous aldosterone secretion. So if you can imagine, if you set a lower threshold, it goes to even higher, a higher prevalence of primary aldosteronism. Now, going back to the same population, they looked across these 4 groups of untreated normotension, stage 1, stage 2, and resistant hypertension. And they looked back and see how many of these would have screened positive with the ARR by conventional criteria. So it turns out the sensitivity of ARR ranges from about 22 to 50%. So very, very insensitive at actually picking up patients with PA. Now you'll see the specificity is quite good. It's in the 90% range for these populations. But the reliance on a high ARR and high aldosterone in the screening stage limits the detection of true cases of PA. Now, why is ARR sensitivity so poor? Well, one of the main arguments on it is that the plasma aldosterone level is not a very reliable measure of total daily aldosterone secretion. And I think this is kind of underappreciated in terms of serum aldosterone. So a single spot measurement of aldosterone does not take into account its cyclic nature. So when we always think of cortisol as this hormone that spikes and goes down throughout the day, but you should be thinking of aldosterone as even more than cortisol for this kind of variability throughout the day. So ACTH is at least as potent a secretagogue for aldosterone as it is for cortisol. And so cortisol is more highly bound than aldosterone and has a longer half-life. So its stability is much more than aldosterone. And aldosterone has much higher peaks and valleys in a day than cortisol does. And obviously, depending on when you sample somebody's blood, you may get a very high aldo level or very low, but it's not reflecting their 24-hour urine aldo secretion. So this obviously has a huge effect on what the ARR is going to measure. And this is shown well in this study from 2015, where this group in Greece took 113 patients with essential hypertension, and they actually did confirmatory testing on all of them and excluded anybody with PA. So these are all true non-PA hypertensive patients, and compared them to 61 normotensive controls. And they gave them all a low dose of ACTH. And then they looked at the patients with essential hypertension and they kind of divided them into two categories. So they looked at those who were hyper responders to ACTH in terms of aldosterone secretion, and compared them to essential hypertensives who did not. And then the next step is they looked at those who hyper responded and those who did not, and looked and see how they responded to MR antagonists. And so I'll show you this figure. It's a bit confusing, so I'll try to walk you through it. So on the top of the figure is looking at changes in aldosterone. And you'll see the three populations here are controls, hyper responders, and essential hypertension. And you can see that the essential hypertension group here that were hyper responders, because their aldosterone secretion level went up significantly with ACTH compared to those who did not. So you see this big gap between hyper responders and non. The middle section is the ARR, which, as you imagine, would travel together with the aldosterone level. So again, there's this hyper responders and there's people who do not. Now look at the change in cortisol in comparison. You don't see this big gap in cortisol when given ACTH. They're all about the same and almost parallel. So that was the first step, as they looked for hyper responders versus normal responders. And then the next step was they gave them MR antagonists to see what happened with their blood pressure. So if the patient was a hyper responder in terms of ACTH and aldosterone secretion after being stimulated by ACTH, those patients, which was about a quarter of the population, their systolic blood pressure dropped by 30 points. Diastolic blood pressure dropped by 15 points. If you were a normal responder, did not see this spike with ACTH, your blood pressure was basically no different if you gave an MR antagonist. So the results suggest that these hyper responders who have essential hypertension, they've been excluded as having actual PA, but they behave like having PA in that they are highly responsive to MR antagonists. In this group, they actually had a prior study where they looked at the prevalence of PA in their population with guideline recommended confirmatory testing. And they found that the prevalence of PA in unselected patients with hypertension in their population ranged from 29 to 32%. And then when you add the 27% of ACTH hyper responders that preferentially respond to MR antagonists, that adds up to about 60% of their hypertensive population with apparent essential hypertension that are expected to respond to MR antagonists and behave like PA. So that's like over half of their hypertensive population would benefit more from MR antagonists than other blood pressure medications. This is also this kind of variability of aldo has also been shown in this recent study in hypertension, where they looked at patients who were screened with the ARR, but they had multiple times where they were screened for the ARR. So all of these people had 2 or 3 ARR screens before being diagnosed with PA, but they all had confirmatory testing that confirmed the diagnosis. But you can see how much the aldo level varies time to time. So the coefficient of variation for aldo in the ARR are 31% and 45%. And you can see that there's a huge range that you see here. Now, these aldo measurements are different units than we typically use, but they looked at aldo thresholds of 15 and 10, because there's some people who believe that for an AR to be considered positive, your aldo level has to be above these ranges. But they show that when you look at variability, that if you set this threshold of 15, just because of aldo variability, 49% of the time you'll be below that threshold, just based on normal variation. And 29% of the time you'll be less than 10. And so you may miss a lot of these people using the ARR. And these ARR thresholds are based on units that are mostly used in the US. But again, 57% of the time you'll miss it if you set the threshold at 30, and 24% of the time you miss it at the threshold of under 20. And that's just because of the variability in aldo throughout the day. And so moving on to a continuum of renin-independent aldosteronism. So what has become increasingly clear is that renin-independent aldosteronism exists as a continuum of disease rather than a dichotomous disease state. And that what we currently call PA is really only the tip of the iceberg in terms of this diagnosis. And I think this is best shown in the Pathway 2 study in resistant hypertension. So just to remind you of the Pathway 2 study, as it was a few years ago, they looked at patients with with resistant hypertension who were already on 3 drugs, and they were trying to figure out what the best 4th line add-on therapy would be. And so they put patients on this the spectrum where they would give them first spironolactone at 2 different doses, and then there'd be a washout period, and then they would try the same patients on doxazosin, a washout period, placebo, washout period, bisoprolol. And so they could compare individuals to themselves in terms of which agent lowered blood pressure the best. And this is where it became kind of common practice to give spironolactone as 4th line therapy because it lowered blood pressure more than doxazosin, bisoprolol, or placebo. But the often overlooked part of the study is that determination of which one was best depended on what your renin level was. So the bell-shaped curve here shows the spectrum of renin throughout this study population. And the lines here show which blood pressure medicine lowered blood pressure the most. So you can see spironolactone in red, bisoprolol in purple, and doxazosin in green. And what you see is patients with low renin are the ones that were spironolactone really had the major benefit. For those whose renin was not low, it didn't really matter which blood pressure medicine you gave. They all had about the same effect. And there's this figure I like in the supplement there where they again look at renin level, and then they look at prediction of which drug would be best based on your renin level. So if your renin level is low, spironolactone is your best drug. When your renin gets really high, all the drugs are about the same. So just kind of another way of showing this, but it's saying based on your renin level, which drug is best for you. And there was this mechanistic study that followed up to the Pathway 2 study that later on was done, where these lines display your blood pressure response to spironolactone for the population. And you can see, again, if your renin is low, you get a better blood pressure response. If your aldosterone level is high, you have a better response to spironolactone. And again, if your ARR is higher, on the one on the far right here, those are the people that are most likely to respond to spironolactone. It's very much a spectrum. It's not so much a dichotomous threshold, but there's a spectrum in terms of the ARR. So the Pathway 2 highlighted that the label of PA is no longer necessary to justify treatment with MR antagonists. And I'll show you, this is kind of, so moving from resistant hypertension to normotension and mild hypertension. I'll show this study that was initially done in the Lancet in 1975, where they took basically healthy volunteers and studied them while they ate their customary unrestricted diet. Then they studied 42 of these people after giving them a very low sodium diet of 10 milliequivalents for 3 days. And then they measured their PRA after 4 hours of ambulation. So again, a very low dietary sodium intake should stimulate your renin levels. So they measured, it was basically measuring maximally stimulated renin levels. What he found was that renin activity after sodium restriction, a sensitive indicator of renin suppression, showed a significant negative correlation with blood pressure. So like the Yanomami, if you were able to stimulate your renin level, your blood pressure tended to be lower, and that was a normal physiologic response. So this was a study we did a couple years ago where we did a similar protocol where we took 663 people with normotension or mild hypertension, gave them a pretty potent sodium restriction and measured their maximally stimulated renin levels. And then we wanted to see, basically, normal physiology is to stimulate your renin levels in the setting of dietary sodium restriction. And those people we think have normal physiology in green. And in red was the people who were not able to stimulate the renin levels. And so the renin remained low despite sodium restriction. And so these are the patients we thought would have inappropriate or excess MR activation. And then to test that, we gave them a high sodium diet and measured aldosterone secretion, vascular phenotypes, and MR activity. And so what we found, again, in red here is the group that we suspected would be the abnormal or autonomous aldosterone secretion group, where they were not able to stimulate their renin levels. And indeed, they had higher blood pressure, they had a higher ARR, and higher 24-hour urine aldo excretion, but below the threshold of calling them PA, as you can see in the blue line there. And then they had lower serum potassium and higher urine potassium excretion, as you would expect with higher MR activity. Moving on to how does this affect people in normotension? So this is just completely normotensive populations. So this was a study from the New England Journal about 15 years ago. They looked at, basically they just looked at aldo levels in quartiles across the population in people with normotension. And then they followed them for 4 years and wanted to see how many would have an increase in blood pressure or develop hypertension over those 4 years. Turns out the patients with the highest aldosterone levels had the highest rates of increase in blood pressure and hypertension. So this is just a graphical display of that if you have higher aldo levels, if you're in the 4th quartile, you had higher rates of an increase in blood pressure or development of hypertension over 4 years. Afterwards, kind of a sub-analysis of this same population, they went to look at renin levels. So this is a confusing diagram to look at, but basically here they break aldo level, which is the A1, 2, and 3 by tertiles, and they break renin levels by R1, R2, and R3. So the group with low renin, high aldo would be the group we would suspect would have the highest rates of incident hypertension and increase in blood pressure, as I've been talking about. And so that is what you see here. This is the highest bar in the low renin, high aldo group, and this is true for incident hypertension as well. And this was also shown in another study a couple years back where they looked at, again, normotensive individuals and looked at the risk for incident hypertension. And they did it based on renin levels. So this was in MESA, which is a large study in the US. And in the study, they had 850 people that were untreated normotensives, and they had 2 follow-up visits, one at 2 to 3 years and one at 3 to 5 years. And they just wanted to see, did they develop incident hypertension over those timeframes? And they broke them down into renin levels. So they looked at this group with a PRA less than 0.5. So this is the group we would suspect would have kind of the subclinical PA phenotype. Indeterminate renin, which was PRA of 0.5 to 1, and then greater than 1. And what they found was that this group that had the low renin, this group that we would think have some degree of autonomous aldosterone secretion, did have a higher rate of incident hypertension over those 5 years. And it was about a 70% higher risk than the other populations who did not have suppressed renin levels. Then they looked at the same study where they broke patients down based on the renin levels. So on the left is the lowest renin group. So that was the group that had higher rates of hypertension. Then they looked at the intermediate renin group and then the unsuppressed renin group. And they looked at the correlation between aldo levels and incident hypertension. So these quartiles are quartiles of aldosterone. And you can see that there's almost a linear description of aldo levels leading to higher blood pressure or incident hypertension in the low renin group. But there's really no relationship in the intermediate or unsuppressed groups. So higher aldo levels only seem to matter if your renin was low. And so just a brief look into what might be ahead of us in terms of primary aldosteronism in the future. So there's this growing recognition of a continuum of renin-independent aldosteronism, which brings into question our current approach to PA, where we only treat the most severe phenotypes of PA. And I think this is kind of very telling here that there's this recent editorial written by John Funder. And John Funder is a very well-known researcher in PA, and he's actually the chair of the guidelines, these are the most recent guidelines from 2017. And his recent editorial says that based on largely what I've told you today, much of the present guideline needs to be completely jettisoned. And so what might the future of guidelines look like? Well, we have to appreciate that renin-independent aldosteronism is far more widespread than we historically appreciated, and it goes well beyond the semi-arbitrary cutoffs that have evolved over time. And then a large proportion of what we currently call essential hypertension is actually aldosterone-mediated. And given the sheer size of this population, where I'm telling you it might be over half of the hypertensive population, obviously a lot of this may kind of trickle down to primary care. And this is just that quote from the Greek study I showed you before, where they estimated that 60% of their patients with a label of essential hypertension actually had aldosterone-mediated hypertension that would preferentially respond to MR antagonists. So should we reconsider the disease terminology? And I think this may be something that is worth looking into because there's historical connotations associated with the term primary aldosteronism that misleads us into thinking this is just some rare zebra disease, which is clearly not the case. And I think pathway 2 and some of these other studies have shown that labeling somebody as PA is no longer necessary to justify treatment with MR antagonists, and that there's this large population that would benefit from MR antagonists that we're currently not tapping into. The other thing I think we have to think about is the ARR, because I've shown you it's very, very insensitive and all the flaws with it. Should we go back to how it was initially developed? So it was initially developed for identifying surgically correctable cases, and it's actually it performs very well in that population. So maybe we should be looking back at using ARR only to identify people who would benefit from getting adrenal CT or adrenal vein sampling, some of these more expensive procedures. Again, this is the exact purpose of how the ARR was originally designed. It just kind of evolved over time into something that it wasn't intended to be. Another thing we need to look at is if we're treating a lot more patients with MR antagonists, we have to realize how do we know we're treating them well? Because again, a lot of these effects of primary aldosteronism occur independent of blood pressure. So some of the biomarkers that are being looked at is normalization of the ARR. And this is a study we published a few years ago. We're looking at renin levels of should we be, again, all these patients start with suppressed renin levels, and should we be looking at renin unsuppression? And this was a study we published a few years ago where we compared patients with PA whose renin levels remained low despite MR antagonists and patients whose renin became unsuppressed with MR antagonists. And you can see that there was much higher rates of cardiovascular disease in those who on targeted treatment, their renin remained suppressed. So they continue to do very poorly. But if your renin became unsuppressed, your risk for cardiovascular disease was essentially lowered to that of essential hypertension. So it suggests that maybe renin is a biomarker we should be using more often if we're treating more of these patients. So just to finish up, this is kind of my take-home points. So PA is a heterogeneous entity with varying definitions over the past 65 to 70 years since its initial development. The label of PA is important only insofar as it changes management. So you don't need to have somebody labeled as PA to treat them with MR antagonists anymore. And I think that's something we need to kind of steer away from. You can no longer rely solely on patients having severe resistant hypertension or hypokalemia. There's a huge population that don't meet these criteria that actually have PA that would benefit from treatment as such. Strict AR cutoffs are completely misleading, and they're better at identifying aldosteronomas rather than aldosteronism. And again, we need to move away from thinking of PA as a categorical disease and think of it more as a continuum that affects a large percent of our patients. Again, it may contribute to over 50% of cases of what we currently label as hypertension, essential hypertension. And we should be using MR antagonists far more often to provide personalized medicine. And I think going forward, we're likely to see MR antagonists change from being thought of as fourth line add-on therapy to something that a large percent of our population would actually benefit from. So with that, I'll wrap up and I'm happy to take any questions. I think you're muted, Greg.
Greg's muted, so I'll talk.
Go ahead, Peter.
I'm muted, sorry. Go ahead, Peter.
Yeah, I have two unrelated questions. The first sort of practical one, if we're using MR antagonists much more widely and maybe no longer only as fourth line, maybe they should move to third or second line in some people. I assume we should watch for response and stop them when they don't work because they aren't going to work in half of people. Mm-hmm. But B, can you comment on dose? Because in classic primary hyperaldo, you need a big dose of spironolactone because of its competitive antagonist and aldo levels are high. These trials, I think, mostly use 25 or 50 of spironolactone, did they not? And what dose should we level out at?
Yeah, I think that's a good point, because if you're picking up milder cases, you probably don't need as hefty of a dose of MR antagonist. So with true PA, I often find that patients need very high doses of spironolactone. So I have patients that are up to 200 milligrams of spironolactone, which many people don't use, but that's actually what they need to respond. As we move kind of the spectrum of more mild forms, I agree that we probably don't need as hefty of a dose. And you're right in that I think if you don't see much of a response to people at like 12.5, 25, that might be all these patients need. And if they don't respond, I think you do need to be able to kind of steer away, because you're right, it's 50% may work for, and that's probably the low renin group, but 50% may not. So I'm comfortable you obviously have to monitor their potassium as well as you do this. But I think this, as we pick up milder cases of this and as the definition changes, I think we're going to be looking at more in the 12.5 to 25 to 50 milligrams of spironolactone rather than kind of these hefty doses we often need for what we currently call overt PA.
And just to comment on, we're sort of back to the future with low renin hypertension now, which was the big vogue in the 80s when I was training, and then got dumped as being a waste of time in the 90s. But back then it was often used as a marker of who might respond to a diuretic or a low salt diet.
Yeah. And I think the low salt diet makes a lot of sense of why those patients would respond, because even true PA, if you can actually restrict your sodium intake enough, you can actually treat the disease without medication. It's just in our Western diets, I don't think it's that possible, but they've done studies where they put patients with true PA and really admitted into the hospital and really restricted their sodium intake. And basically their ARR normalizes and their blood pressure normalizes. It's just almost unsustainable based on our Western diet to restrict that much, because you really need the substrate of sodium to really drive these patients' blood pressure. But it makes sense why low renin hypertension would be so responsive to sodium restriction more than others.
Brendan, do you have a comment there?
Yeah, thanks, Greg. That was a great presentation. One new thing that I learned from this is the concept of the phenotype of the hyperaldosterone patient who may just be hyper-responsive to ACTH. And of course, not picked up often by an elevated ARR. And it got me thinking, we often see quite significant morning surges in blood pressure in some patients. I mean, everybody tends to have some surge, but some really surge. And we know the diurnal secretion of cortisol is such that it corresponds with that surge in morning blood pressure. Are you aware of any studies that have actually looked at those patients with an excessive morning surge in blood pressure and correlated it all to their urinary aldosterone excretion, or looked at the use of mineralocorticoid antagonists in those patients with an excessive morning surge in blood pressure?
Yeah, no, I think that's an excellent point. And I don't know of any studies that have looked at that, but it makes a lot of sense to do, because especially if we're seeing these spikes with aldosterone that are even more significant and driven by ACTH than cortisol is, it very well may be an explanation for why we see that. And it may kind of guide how you actually would want to treat those patients, because it may be very different than what we currently do.
And with the volume of ABPMs we do, it wouldn't be too hard to have a look at that.
Yeah, I think that's a great idea.
Greg, thanks again for that great talk. And before everyone takes off for their busy day, I just have a couple of announcements. I see that Dr. Bell is on the line for the